So, on behalf of Odisha Association of Physical Medicine Rehabilitation and Department of PMR, Physical Medicine Rehabilitation, and Indian Association of Pain Medicine, we welcome you all to this webinar. As you all know, actually this webinar was the plan for a hands-on workshop. Due to some technical problem, we had to cancel that physical mode. Then we went for this online mode, virtual mode. So I welcome you all to this webinar. Today is a very interesting talk, and that is our one of the important part of our physical medicine rehabilitation, as well as our anesthesia friends also. So many people are now very much interested for pain management program. We are very much fortunate with us. We have with us Professor Dr. Sovan Kumar Rath. He is one of the eminent pain practitioner in Odisha. You can say in Odisha he is pioneer of establishing this pain clinic. So he is currently working as director Pain Free Odisha, and also he is chief pain consultant in Health Village Hospital, Bhubaneswar. He is also professor and in charge of Pain Clinic, High Tech Medical College, Cuttack. He has finished his MBBS from SC Medical College, Cuttack, and he has done this fellow in pain practice from Maastricht University of Netherlands, and he has organized a very great conference, wonderful conference very recently, where there were a huge gathering of our friends from PMR, friends from anesthesia. I was also part of that conference. I was really surprised to see that such a big gathering of and so many people are interested in pain practice, and the conference was a really eye-opening conference. Many things were there, starting from tip of the toe to the brain. So it was really we must congratulate Dr. Sovan for organizing such a wonderful conference. And without much wasting time, I think I must welcome Professor Dr. Sovan Kumar Rath. He will speak on this chronic pain management basic part. I hope his presentation will certainly enlighten so many areas of pain management, and certainly it will be useful for all of us. Thank you, and welcome Dr. Sovan Kumar Rath.
Thank you, sir, for the nice introduction. Delighted today to present a few topics in front of all the nice gathering. Actually, as I said, it was on a physical mode. We have planned that we will go for one lecture followed by physical demonstration on the patient, how we are going with different kinds of interventions. What is pain and how is it affecting our daily life? And the second part is how we are going to get rid of that pain with different kinds of interventions. So basically, interventions that we are doing is by blocking the nerve so that the proper pain channel that is reaching the vein, the transmission can be cut down in the middle, we can say. So there are various methods. So before going into that, actually, I had prepared all these slides, keeping in view of a physical presentation. So there are 2 or 3 slides are there. I'll be skipping in between. First of all, I'll give you a brief introduction of what is the pain management and what are the different aspects from head to toe that we cover. Then the second part, I'll be telling you how we do different kinds of fluoroscopic procedures. Third, we'll go with the ultrasound procedures. Now, ultrasound, it is not possible to go in a detail, but I'll try to convey something about this shoulder ultrasound, because that is the most common that we are seeing, shoulder and the knee and the ankle and elbow. Out of that, I'll try to cover a few parts of the shoulder. So to start with, basics of pain management. So I'm practicing this pain, you can say interventional pain, since last 12 years. Almost in 2010 when I started this, there was almost no pain clinic per se, where we were doing some kind of interventions. We are just hearing that these kind of blocks are there. But because my MD was in anesthesia, so I was little bit, I knew about the different kinds of nerve blocks possible. But apart from that, these nerve blocks are particularly for the acute pain. Whenever there is some kinds of trauma, or as an anesthesia procedure, or as a post-surgical pain management, these procedures can be done. But when it comes to the chronic pain, the modalities are different. Now, what we will be discussing is what is pain, what are the pathophysiology of pain, newer concept, newer drugs, and what are the interventions that are there. Definition of pain, as we all know, an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. The last line is very important because there may not be any physical damage to the tissue, but it's possible that the patient is feeling some kinds of pain. And the most appropriate example is a phantom limb. There is no tissue damage over that area. Because of the absence of the limb, the patient is having pain in that area. So what are the different kinds of pain? Particularly acute or physiological pain, and chronic or pathological pain. Acute pain is a nociceptive one. Symptoms of disease and treatment of disease cures this pain. Whereas chronic pain is a neuropathic pain where the nerves are involved, and it's a disease itself, and it's difficult to treat. And in acute pain, it's a simple relationship between pain and tissue damage, whereas chronic pain, this is a dissociated relationship between pain and the tissue damage, that is disproportionate to the kind. Basically, pain is an alarm. So true for acute pain, which is our friend, chronic pain is a false alarm, which is a disease itself. So what is called a chronic pain? Something which is persisting for more than 3 months, even after going for a conservative therapy of medications and physiotherapy, everything possible in a conservative mode. Even after 3 to 6 months, if it is not getting cured, then we call it as a chronic pain. It can be with an ongoing tissue damage or without a tissue damage. But the main issue is the central sensitization. That is a constant feature in both of this pain. Now, this is the pain pathway. We all know about this. There is a nociceptors, they go through the spinothalamic tract, reach the brain. Then there is a descending inhibitory pathway through which the other responses come down. So this is what we know from our early days of study. Now I'm skipping these parts. Now there are two parts of sensitization. One is a peripheral sensitization that occur at the periphery. So sensitization of the primary afferent terminals at the level of the nociceptors where the pain is felt or where there is a tissue damage. At that place, the damaged axons sprout and form the collaterals with the adjacent tissue. So this is called periphery or peripheral sensitization that occurs at the peripheral level or at the sympathetic levels that invades the DRG. But when it comes to a central sensitization, what happens? There is signals, those signals causes oncogenes and like C4, C oncogenes, they activate this, that releases neuropeptides and nerve growth factors that alters the pattern of the nerve connection. So what happens in a single level, the nerve that goes to suppose rexal lamina 2 or 3, adjacent rexal laminas are also involved through that. So that a single pain at a single level can cause pain at the multiple levels, which happens in CRPS particularly. So these are the phenomena that occur in central sensitization, that is central reorganization, wind-up phenomenon, upregulation of the NMDA receptors and ectopic activity, depression of the inhibitory synapses and activation of the WDR cells. So we'll not go into the details of this. So what happens with the results of
central sensitization that increases the intensity of pain, increases area of pain, increases duration of pain, decrease the tolerability of pain, development of psychological problems, and pain becomes non-responsive to conventional analgesics. So character-wise, chronic pain, apart shooting, electric shock like, and usually associated with numbness, tingling, pruritus. Sympathetic symptoms may persist like redness, edema. Those things occur in CRPS in particular. Now, the treatment approach to chronic pain is multimodal. It's not about only medication. It's not about only intervention. It's not about only blocks. So it's or only physiotherapy. So it's a multimodal approach from all the levels so that pain can be properly treated. So we start with the combination of different kinds of analgesics, then adjuvant therapy, then physical medicine, and then interventional pain medicine possible. And if some patient there is a psychological event, then we have to go for a psychological intervention. So to treat with the acute pain, we go with the NSAIDs and at some cases tramadol or low doses of opioids or regional anesthesia for acute pain for blocking the particular nerves. Now for the chronic pain, the first is you stop the nociceptive input, then you go with the neuropathic pain. And what happens in neuropathic pain, you have to go with the drugs that are acting on the nerves, in particularly calcium channel blockers and sensitizers. So and also different drugs that are acting on the descending inhibitory pathways like tramadol and TCS. So these are a combination of drugs that can be used in case of chronic pain. Now, where is the role of interventional pain? This is what is a WHO ladder pattern. You must have seen that we start with a non-pharmacological methods, then non-opioids, then weak opioids, then stronger opioids. At last, if it is not possible, then we go for an operation. But there is a large gap between the medication and the surgery. And that gap is being filled up with the interventions, which is a walled up mystery that nobody knows what to do in that gap. So we have given it a term that is minimally invasive pain and spine intervention. This is a new classification that has come, that is MIPSI, minimally invasive pain and spine intervention. So what we treat in this, starting from head to toe, migraine, headache, neck pain, spondylitis, low backache due to various causes, sciatica or radiculitis, osteoarthritis knee, trigeminal neuralgia, post-herpetic neuralgia, fibromyalgia, and all kinds of cancer pain, neuropathic pain, and labor pain. So everything can be taken care of. Now, earlier days, as I said, we were using two things, either local anesthesia or a steroid combination. Now, what extra do we have at the present time? We have got platelet-rich plasma. Platelet-rich plasma, blood is taken from your vein. That is almost like 20 ml of blood is taken, and it's centrifuged in a PRP kit, and we take out the platelet-rich plasma. And the basic role is, we can say, it just acts like a stem cell. Where there is a tissue injury, if you put that PRP at that level, particularly at the tendon injuries, in epicondylitis, also in the joint also, so it causes a healing, it increases the healing procedure, so that particularly we have seen in tennis elbow, golfer's elbow, in the knee joint, in ligament splints, in those areas it can be put. And what we are doing is, we are putting this PRP nowadays under ultrasound guidance, so that properly it can be put in the areas where is required. Next is radiofrequency ablator. Now the radiofrequency ablation, what we do is, we ablate the radiofrequency, we ablate the nerves or the dorsal root ganglion that is basically supplying the channel, and you are feeling the pain. So it can be used from head to toe in various, particularly regular basis. That is, one is the trigeminal neuralgia. We go for the Gasserian ganglion radiofrequency ablation. Particularly in the low back pain due to facet joint, we go for a median branch block.
For the SI joint, we go for the SI joint ablation. In a hip joint pain, we can go for a knee joint osteoarthritis, we can go for a genicular nerve block, also for the foot pain. So there are various areas where it can be put. What we do is basically we burn the nerve so that you won't be feeling the pain. Particularly, we burn the sensory part so that the motor component will not be affected and only the pain sensation cannot be felt. Next is when nothing is working, we can go for spinal cord stimulator. These are advanced modalities. We will not be discussing those things now. Now, another, just like PRP, another is a prolotherapy. There's a combination of ozone and dextrose in combination that again acts as a what we can say is a growth factor. So that also enhances growth. It can be used in place of PRP. Everything is ultrasound guided and otherwise fluoro guided. So all the procedures, we are not nowadays putting any needle blindly. Either it is fluoroscopic or we can say ultrasound guided. These are the different levels where the different drugs are acting. Now I'll be coming to different examples. Now suppose it's a complex regional pain syndrome. What happens? You must have seen these patients. There is particularly trauma and the trauma has been healed, but there is remnant of swelling and redness persists and pain persists in that area. Particularly, we have seen, suppose there is a fracture in the forearm, either that has been taken care of by a surgery or by the cast. But after a few months, you see that pain is not subsiding. Rather, you have got swelling over that extremity, redness is present, skin texture is glistening, and pain increases gradually. And that is disproportionate to the injury. It means it is not only present at the area of the injury, rather at the extremities, it is also affecting, so that it has been termed as complex regional pain syndrome. That is on the upper limb and the lower limb. So what we do is we go for a sympathetic plexus block. That is, if it is the upper limb, suppose anything with the arm or the upper limb, upper chest, or anything with the head and neck, cancer is affected also, we can go for a stellate ganglion block. That is at this level. You can see we're putting a needle at this level, putting a dye so that we see a proper dye spread, and we can go for a local anesthesia injection. That is a diagnostic block. Now, if we want to go for a permanent block, we can put a radiofrequency ablation or alcohol. We can do a stellate ganglion block. Now, there are various indications wherever there is upper extremity CRPS. The causes are either it can be vascular causes, it can be CRPS due to any other cause, and also the phantom limb pain, also the herpes zoster, and pain in the head and neck. These are the different indications. Now, what happens if the same thing is happening in the lower limb? Then we go for, these are the various indications again: neuropathic pain, urogenic pelvic pain, also cancer pain, phantom limb pain. Also, we go for a lumbar sympathetic block. So where we do this lumbar sympathetic block, that is basically L1 and L2, or we can say L2, because all the sympathetic plexus that is coming from the lower limb is going through L2. So that is particularly the level where you put a needle. Either you can go ahead, like this is what you see. First we see in a lateral view, in an oblique view, position the needle. Then after that, this in the lateral view, you see there is a proper dye spread along the sympathetic plexus. Then either you can do it with alcohol, or you can do a radiofrequency ablation. This is the example of various where we do a stellate ganglion block. It can be done in a post mastectomy patients where there is lymphedema in the upper arm, in the phantom limb, or there is gangrene, if there is gangrene in the upper limb. For the lower limb, you can see again any kind of CRPS, phantom limb, or if there is any kind of gangrene in the lower limb. Also, so in all these cases, we can go for a lumbar sympathetic plexus. Diabetic neuropathy, nothing much to do. We won't be discussing much because the primary treatment is good glycemic control. Other things can be tried, like simple epidural can be tried, but these are of not much benefit. Next is trigeminal neuralgia. What happens in trigeminal neuralgia? There is a pain, lancinating pain, electric shock-like pain in the face.
So to that again, we can go for a Gasserian ganglion radiofrequency ablation. We put a nerve through the foramen oval and we can block that area. Also, if there is any kind of attack which is not responding to medication, we can go for a spinopalatine ganglion block. Particularly, you must have seen post-herpetic neuralgia. Herpes usually occurs in a single dermatome. If in that dermatome it stays for a longer time, then it may reappear pain after a month or so. So in that case also, we can go for different kinds of pharmacotherapeutic agents that we know: gabapentin, nortriptyline, amitriptyline. These are the drugs that can be used. If this nothing of this is working, then we can go for interventions like, again, sympathetic blocks, intercostal blocks, paravertebral blocks, neuraxial blocks, or at last spinal cord stimulators can be put. Now, one interesting patch has come up now, that is a lidocaine patch. Earlier, it was not available in India, but now it is available with a single company, that is Modi Mundri Pharma is bringing this. What we have to do is, when the lesions are healed up, put these patches over the area and we keep it for 12 hours. It's 12 hours on and 12 hours off. You continue this for about a month or so. There is excellent pain relief in case of post-herpetic neuralgia. And in many cases, I have seen that we don't need interventions again. Fibromyalgia, drugs, we know. What extra we can go for trigger point injections. Some people use botulinum toxin. Myself, I'm not using, but it can be used. Osteoarthritis knee, again, those osteoarthritis grade 1, grade 2, or initial stages of grade 3, not in advanced grade 3 or grade 4 where there is mechanical deformity and tissue damage is so much that regenerative procedure cannot work. We don't have much to do in those cases. In initial stages, if it is not working good with medications, what you can do is intra-articular injections of viscous supplement, number 1. Number 2 is a platelet-rich plasma therapy that acts like a stem cell therapy and that grows the residual tissue that is present. In case of, if it is due to the post-injury osteoarthritis because of some ligamentous injury, tissue injury, meniscus injury, that can also be treated with this. If now you see that even after doing anything is not working, or it's advanced stages where you cannot go for a knee replacement surgery, patients do have many complications like cardiovascular complications, diabetes, many things are there. In those cases, what we can do is we can block the genicular nerves. Though the mechanic
Sovan, you are not audible. You unmute yourself.
Hello.
Yes, now you are audible.
Okay, there were some internet issues, I think. Okay, now I was telling about the intra-articular injections like viscous supplement. The next is regenerative therapy, that is injections of the platelet-rich plasma in earlier stages, or in those cases where there is a advanced stages where we cannot go for a what we say knee replacement surgery. In those cases, what we can do is we can go for a genicular nerve ablation. Though with this, mechanical defects cannot be taken care of, but at least patient will be painless, and with braces and all, patient can walk nicely. Now, particularly for the shoulder pain, there can be various reasons. Nowadays, ultrasound just is a boon for us, so that we can at least diagnose if there is a AC joint pathology, is a labral pathology, if there is calcific tendinosis, or there is a rotator cuff tear. It can, or everything can be diagnosed with ultrasound, if not with the MRI. So, what are the different procedures we do? Either intra-articular injections can be put, number 1. Again, of the same, we can go with a PRP, we can go with steroids, we can go with viscous supplement.
Now, if not, we can go for various nerve blocks. That is either a suprascapular nerve at the suprascapular notch or at the supraglenoid notch, either both the places. If not, we can block the radio, we can do a radio frequency of the articular branches supplying the shoulder joint. So particularly what we do is in a frozen shoulder or a periarthritis shoulder, we just try to find out the cause. If it is due to arthritis of the joint itself, either the AC joint or the glenohumeral joint, we can go for intra-articular injection number 1. If not, we can go for a radiofrequency ablation. Particularly if it is due to neck pain, we can go for a maximum causes are because of the facet joint. So what we do is we put a radiofrequency probe, we do a ablation of the median branch that is supplying the facet joint. That's the easiest thing possible. Then the most common one, that is low back pain. Low back pain can be due to various reasons, but these are the 3 things that is the most common cause. Number 1, that is because of the disc herniation, disc rupture or annular tear. We'll have a central back pain, but it is not radiating. But if there is a huge disc, then there will be radiating pain. Next is sacroiliitis. The third one is a facet joint pain. So if there is disc herniation, particularly there will be radiating pain, numbness, tingling sensation along that nerve, and from the dermatomal distribution, we can say that whether it is L4-5, the most common one, whether it is L5-S1 or which. So from the dermatomal distribution, we can say which nerve is affected. So accordingly, we can go for either an interlaminar epidural, or we can go for a root block, transforaminal injections into the particular nerve which is affected, or we can go for a caudal injections, or particularly DRG, radiofrequency ablation. All this can be done in these patients if there is a disc bulge. If there is a discogenic pain per se, where the disc herniation is less, but it is more of a discogenic pain because of the annular tear per se, what we can do is we can do a ozone discolysis, we can put a radiofrequency probe, and we can go for a nucleoplasty, or we can suck it out also. So there are various techniques through which discogenic pains can be treated, but nowadays we are only doing nucleoplasty so that the infections rate are very less with that, instead of putting many drugs or ozone into the disc. The result we have seen is not that good as that of the nucleoplasty. Also, when we are going for a discogenic pain with a nucleoplasty, we can do a rami communicans radiofrequency ablation can also be done with that. Now, if it is because of the sacroiliac joint, again, the primary treatment is injections into the sacroiliac joint, which is done under fluoro. Otherwise, what we can do, if it is the results are good and the patient is not responding to only to the medications, injections, then we can go for a radiofrequency ablation of the whole of the starting from the top to below. Every supply can be blocked with radiofrequency ablation. Now, if it is because of the facet joint, then what we can do is we can go for a same as in case of a cervical facet, we go for a radiofrequency ablation of the facet joint. Now, there can also be various pains because of the tailbone pain. The most very common, the patient is complaining that I'm not able to sit on a flat surface. What we do is basically we can go for a ganglion impar injections, or we can give him a cushion. Ganglion impar injection is just putting a needle at this place, and that works very nicely. You can go for a single setting or multiple settings, but it works very nicely with only steroid and alcohol. We don't, steroid and local anesthesia. Now, another is if there is a failed back, if you have done a surgery, but even after that, that is persisting, we can go for a, usually it is because of adhesions inside the spinal cord, we can go for a percutaneous adhesio lysis, means lysing those adhesions, or we can go for a spinal cord stimulator. Again, we'll not be discussing much about spinal cord stimulator because that is the most beautiful aspect, but it's out of our scope now. Now, how we do a percutaneous epidural adhesio lysis? We put, now this is, you see, first we put dye through the epidural needle. We see that the dye distribution is less on this side, then you put the rags catheter and lyse those adhesions. Then after that, you put a dye and you see that there is proper dye distribution along both the sides. So that is with the rags catheter. Now, if there is any bone fracture because of malignancy or osteoporosis, we can go for a vertebroplasty along with the epidural injections. The vertebroplasty can be done with a cement or with a balloon. Both the things are possible. Now, in case of various cancers, there are many drugs, but the best thing that is available now is the patch. Nowadays, you don't have to rely on the medicines that is to be taken orally only. There are various patches are coming, that is epidural patch, opioid patches that can be put over the skin and it is absorbed subcutaneously and gives an adequate pain relief. So these are the various things, and otherwise we can go for a neurolytic blocks, particularly of the different areas. In the neurolytic blocks, we just block the sympathetic system, particularly suppose it is of the upper abdomen and upper areas, we can go for a celiac and splanchnic. Of the lower abdomen, superior hypogastric. Of the anal area, we can go for a ganglion impact. So various blocks are there which can be used. So these are, in a nutshell, I have told that what are the procedures that we are doing. Now, I'll be going to the next one, that is how we go ahead with the procedures. I'm coming with the second, Now, how we do a procedures under fluoroscopy. That is the most important thing that everybody should know, the fluoroanatomy. Now, coming to the fluoroanatomy, we'll be discussing only the lumbar spine. Nothing much, because that is the basic thing that we should know how to read. This is basically the disc. This is the disc. These are the vertebrae. This is the transverse process. These are the mammillary
Sovan, your
process.
slides are not shared. Probably you are showing some slides which is not visible here on the screen.
Just a second.
So please share your slides.
I think it's visible, sir.
Yes. Yes.
Yeah. Now, this is the particular lumbar anatomy, lumbar spine anatomy. You see, this is the vertebra, and these are the facet joints. This is spinous process, and this is how this looks under fluoro. What we have to imagine is, we have to imagine a 3D picture in a 2D image. So this is basically an image intensifier, or what we say is a fluoroscope, where we put X-ray and through the body that goes and it's taken up by the image intensifier, and that we see in a monitor. This is what everybody knows about it. Now, patient position can be according to the area that we are doing. Particularly for the lumbar spine, usually the patient should be prone and it should be focusing on the lumbar spine. Now, it can be AP, it can be oblique, or it can be lateral. These are the three things that we see, either a anterior posterior view, oblique view, and a lateral view. Now, this is how we should visualize, and we should, because the lumbar spine is not straight. This is what the curvature is. So according to the curvature, the area that you want to focus, accordingly you have to turn this is suppose the fluoroscope that you are seeing. If suppose the position is a AP position, so that it is only L34 or 45 is visible. Not even the 45 disc will not be visible, because this is in this angle. So only the L34 disc will be visible, others will be blurred, or it will not be properly visible. So to see those vertebrae and the disc, what we have to do is, we have to make a cranial tilt like this, so that again the rays will be parallel to the body and it can be seen properly. This is what is a normal X-ray spine. So what we see is, this is the body, these are the spinous processes, and these are the pedicle, which is forming the facet joint. On a lateral view, that was AP. On a lateral view, you see these are the articular processes, and this is the pedicle, and these are the disc. Now, first, when you put the fluoroscope, you have to make a squaring of the vertebra. Squaring of the vertebra means the upper and the lower border should be in a single line. It should not be, there should not be double line, so that you can do the procedures properly. Now in an oblique view, this is the oblique view, just make it almost 30 to 45 degree angulation. That's again according to what are the structures that you want to see, whether it will be doing 30 degree, 10 degree, 15 degree. So that is according to the structure. So no degrees are fixed, like I'll be doing 10 degree for all or 25 degree for all. That is not fixed. It varies from body to body. What are the structures that you want to visualize? Accordingly, you angulate, so that you will see this Scotty dog appearance will be visible. So what is a Scotty dog? How is it formed? Can you imagine that this is the Scotty dog that we are talking about? Okay, this is the eye that is formed by the pedicle. The superior articular process, this is formed by, this forms the ear, and the body is formed by the lamina and the spinous process, and these are the hind legs, and the anterior legs is formed by the anterior, this inferior inferior articular process, and this is the nose. Now, what are the various structures we will be pointing at? Because whenever we will be going for any procedure, the first or the primary image is the oblique view, where we will be putting the needle. Okay, so where we will be putting, this is the oblique view. Everybody can recognize, I think. So intra-articular facet, just try to visualize. These are the facet. This is the superior articular process. This is the inferior articular process. So for going intra-articular facet joint, what we do, the facet joint is a very small joint. So to put any amount of, we can put maximum 0.3 or 0.5 ml of steroid or local anesthesia into that joint, otherwise it will burst. So this is the location where you have to go if we are going for an intra-articular facet joint. Now if you are putting an intra-articular needle and the patient is having adequate pain relief, it will not be long lasting. So you have to go for a radiofrequency ablation. Now the radiofrequency ablation, the needle position is this. This is the position of the medial branch that is at the junction of the superior articular process and this nose. So this is the junction where your medial branches are present. You have to go parallel to the body, because if you connect like this, then if this is the nerve and this is the needle position, at the tip there won't be any burning. So you have to put the needle just parallel to the nerve so that it can burn the nerve easily. Now this is the position of the transforaminal disc approach, just in front of the superior articular process. Your needle position should be this if you want to enter into the disc. Now just at the 6 o'clock position, it is just below the pedicle. At the 6 o'clock position is if you want to enter into the foramen, so that you will putting a transforaminal or a selective nerve root block, or you can also go for a dorsal root ganglion. RF can be done. Okay, so this much is the basics of lumbar spine. If anybody is having any doubt on the fluoroanatomy, I think everything is clear in this. This is the image that we have to see. This is the facet joint. This is the position for the medial branch block. This is if you enter into the, if you want to enter into the disc. This is if you want to enter into the foramen or selective nerve root block. These are the positions which is required. Now, if you want to go for a sympathetic block, this is what the position is, just anterior to the vertebral body. This is what the position of the, if you want to go for a sympathetic plexus block. Otherwise, these are the 4 positions which is to be remembered, which probably if we will be doing a physical meeting next, I can demonstrate all the methods how we are going ahead. So this is in a nutshell how we are doing the fluoroscopic guided procedures. Now the next one is how we do. When we put a needle, just to confirm your needle position, you have to put some amount of dye. Now that dye, what is the dose of that dye and what is that dye? That's a radio opaque dye that can be visualized in under the fluoroscope, and the maximum dose is 3 gram per day for a recommended healthy body. Now this much for I think I have explained everything here, and we can do one more thing is, this is almost for the procedural fluoroanatomy. Lumbar facet, I have already told. Transforaminal injections. Okay, I'll be showing those images only. I'll be just showing the images how we are going ahead with, not the theories that I was telling you. These are the same images that I have already shown. Okay, so there is nothing much. But now there is one thing that you have to see how to, because back pain is a varied pain. You can be having a midline pain, it can be bilateral pain, it can be radiating pain. So particularly facet joint pain is a pain that the patient can pinpoint at a particular point, and on facet loading to that side, the pain increases. That is the diagnostic point for the lumbar facet joint. And if you're putting an injection, it will be pain-free. Again, transforaminal. Let me show you the transforaminal, how the dye looks. If you are going ahead with, this is how the lumbar. Now, I was telling about how to go ahead for squaring. Now you can see the lower vertebral border is not squared. You are seeing two level, you are seeing a single line. So at needle, that should be squared properly. Your needle will be at the wrong entry point. So now you can see, just compare. This is what the lower level. Now you see, it's a vertebral end plates has been squared. Now you make an oblique view. Now after making an oblique view, for entering into the foramen, transforamen or selective nerve block, position is just below. It's a 6 o'clock position. Now I'm putting the needle. Now you see in the lateral view, you have to confirm that the needle is just at the top of this foramen. This is what the foramen is. Now after that, what you do is put some amount of dye. The dye will be distributed along the nerve so that you can confirm the position, and after that you can put some amount of local steroid and local anesthesia into the joint.
Okay, so there
yes,
are
sir.
some queries that
Yes,
selection of patients.
be able to cover up the ultrasound because already 1 hour is almost gone. So
So am I audible now?
Yes, sir. I'm audible.
Yes.
You are audible, sir.
Okay, so there are some queries like
Yes, sir.
regarding patient selection. Okay,
Yes, sir.
so how do you select cases for selective foraminal block, for epidural steroid, or a root block, or facet block? From clinical way, how do you decide, how to select your cases? Yes, I will go for this type of block.
Now, whenever the patient is coming with a back pain, the first thing is whether it is only back pain or it is back pain associated with a radicular pain. Now, we have to keep in mind that all these pains, whether it is a disc only or it is means discogenic pain, or it is a discogenic pain associated with a protrusion so that it is impinging upon a nerve, so that radicular pain is also there. Also, in case of a facet joint, also we have seen the distribution is along the thigh also. In SI joint, again, it won't be at the SI joint only. It will be spreading to the buttock. It will be spreading to the thighs also. So what we have to see is first a clinical history. Now, where is the pain? If it is only back pain, so PIVD means disc protrusion.
Discogenic.
Yeah, it's purely either it can be discogenic or facet or SI. Disc protrusion is out of the course. Now, out of these three, whether the patient is having pain, if there is facet loading, upon turning to that side, if that is causing pain, then it is more or less a facet joint pain. Usually, it's on one side only. And if there is a SI joint pain particularly, you can do the tests or maneuvers that is particularly possible for the SI joint, through which you can see if it is a SI joint pain. Now, in a radicular pattern, usually the pain is radiating down the leg and there will be associated with tingling and numbness. And usually, whether there is central canal stenosis or not, again, all these things can be ruled out through the MRI. Apart from the clinical judgment, it can be also ruled out through the MRI. So accordingly, we can judge whether we want to go for a epidural injection. Now, actually, nowadays, this translaminar or interlaminar epidurals are not given that much unless until the pain is not being identified, or it is because of adhesions. We are not going for caudal or this interlaminar epidural. Particularly, suppose L4-5 disc is there and it's causing pain, so we go for a transforaminal root block or selective nerve root block of L4-5. Suppose it is a facet joint which is causing pain, then the single facet is supplied by two nerves, that is one from coming above and one from the same level. So we have to go for the injections up to all the two levels. For SI joint, again, the diagnostic block itself causes the diagnosis. After putting intra-articular injections, patient will be totally painless. So that again qualifies that the patient is having SI joint pain. After that, we can, confirming this, we can go for the permanent blocks with the radiofrequency.
Do you always go for this diagnostic blocks first before planning for a permanent procedure?
Yes, sir. Diagnostic block patients should be having more than 50 to 70% result with the diagnostic block. Then only we go for a radiofrequency, because the radiofrequency procedure, you are damaging a structure and it should never be tried as a first line of practice. And again, it is costly affair, because for putting a steroid and local anesthesia, you may not charge much, but for doing a radiofrequency ablation, we have to charge the patient.
Moreover,
So again,
many organizations, they don't have radio frequency facility also.
yes, sir. Our station, we can say, is the only hospital where we have a radiofrequency ablation for last 12 years. And the results with the radiofrequency ablation, again, we have seen that the results are very good, because we are not hampering the motor part anywhere. And before going for ablation, we are testing the sensory and the motor part. So there is less chance that the motor part will be affected, and only the sensory part is going. So patient won't be feeling any kind of pain in that. Even in those of the inoperative cases, or where the patient cannot go for a surgery, we have gone for dorsal root ganglion RF, where there is compression. So that's also gives a good result. So that is particularly for the older patients or the patients which are not able to go for any kind of surgery. Again, the same thing with the knee also, because anybody with a grade 4 osteoarthritis will not be coming for these injections. Only those patients who cannot go for a surgery or cannot go afford the surgery, we go for a radiofrequency ablation.
What is the strongest indication for you, caudal epidural? Do you still practice caudal epidural?
Yes, sir. We are practicing caudal epidural regularly, because in many times what happens that you cannot identify the cause, and patient is not ready to go for a diagnostic, like patient will not be ready to go for an MRI, or patient is not able to go for an MRI. In those cases, that is number one. Number two, if there is adhesions at a particular level in failed back surgery patients, in those patients, this works very nicely, because along with the steroid and local anesthesia, we put some amount of hylage, or if it is possible, 3% sodium, so that some amount of hydrolysis can be done at that level, so that the nerves will be clear. Otherwise, routinely, we are not practicing caudal epidural.
Is that MRI, doing MRI is must for going any sort of spinal intervention, or you can go ahead without MRI also?
No, sir. Nowadays, because the complications rate are increasing, So we are making it mandatory so that we won't be missing anything. Because if you are missing anything, no doubt there won't be any side effect with local. But if there is anything we're missing, like a tumor or some amount of compression which cannot be cured with the steroid or local injection, then that has to be taken care of. So we are trying that if it is possible, go for an MRI. Those patients who are not possible to go for an MRI, we clinically we decide whether it is L4-5 or L5S1 according to the dermatomal distribution, and we go for the injections. Maximum time, because government has made it free now, so it is becoming very easy to go for an MRI.
One more question regarding piriformis syndrome. Many times we confuse. I mean, when we check for a SI joint, that time also we need to go for adduction, internal rotation, which stretches piriformis also. So that confuses whether the pain is coming from piriformis or coming from the SI joint. How do you differentiate these things?
So first, clinically, we can diagnose with the various tests that is there, that whether it is piriformis or not. Second is a diagnostic block. The best thing is differentiating between a SI and a piriformis is the diagnostic injection. In piriformis, when we are putting injections into the piriformis muscle, the pain relief is adequate. Again, in SI also, if you are putting injections into the SI joint, that will be painless. But in piriformis syndrome, if you are putting SI joint injection, patient won't be feeling any kind of relief with that. So diagnostic block is very nice in differentiating these two apart from the clinical diagnosis. And there is a butter pain. Yes, sir.
For piriformis syndrome, where do you put injection towards to the piriformis fossa of the femur?
So actually, what we see is under the fluoroscope, when we divide that coccyx to the lateral femoral condyle, so we divide that into 2/3 anterior, 1/3, and the posterior 2/3, and that junction, or maximum I can say at the 50-50 level, directly go in. We put some amount of dye. There is a proper dye distribution. I don't have the picture of piriformis now. I'll show you sometime. Okay. There is a proper dye distribution along the piriformis muscle, and that is the best part. That again, we can do it under ultrasound also. The muscle is easily visible under ultrasound, so that we can put the injections into the muscle, and that gives excellent pain relief.
Okay, so I was waiting questions from audience side. So far, I have not received any question from audience side. I'm going on asking question you. So so far there are no questions. Any question from postgraduate students? Amit, Rajna. Hello. Yes, any questions from postgraduation side, postgraduate student side? Any PG students having any query?
Sir, am I audible, sir?
Yes, yes, you are audible.
Sir, if the patient is suffering with grade 3 or grade 4 spondylolisthesis, and also there is bladder involvement, and patient doesn't want to go for surgery, so can we give epidural in that case, or should we avoid it?
No, we can, but the first golden rule in anywhere, whenever we are touching any kind of nerve and there is a red flag sign, we should not go for any intervention. That is the first rule that everybody should follow. But if you are seeing a patient who is not able to go, it's not that patient is not interested to go for surgery. Because if the surgery is the only thing which is mandatory, it is not up to the patient's choice. And that case, we should not trust the patient. But if in some case patient is not able to, we cannot take the patient for surgery, then we can do it for pain relief. Otherwise, we should not touch the patient if there is any kind of neurogenic bladder, or if there is any kind of red flag, which is to be dealt with a neurosurgeon or orthopedician who are doing a spine surgery.
Which one is a better comparison to steroid versus radio frequency ablation? That is a question.
Obviously, these steroids are short lasting. Maximum 3 weeks to 3 months is the duration of action, what we say. But radio frequency ablation is a permanent, not permanent. Maybe it works for almost like 2 to 3 years. So that is no doubt better than steroids. Steroids are very short lasting and you cannot go on putting steroids every 3 months to the patient. But there are areas where we have to go for steroids if there is they're going for a diagnostic along with some kind of therapeutic. But for a permanent relief, we need to go for radiofrequency ablation.
So can I ask one more question?
Yeah.
Yes, you can, please.
So, sir, suppose if patient is suffering from low backache, so along with it, he might be suffering from depression or many such symptoms. So what will you advise, sir? Any lifestyle modification that is specific to these cases, or just therapy would suffice?
No. As I said in the earlier slides, that it is a multimodal approach. There is never any single either medicines only or interventions only or physical medicines only. So there is everything has to be used in a what we can say in a comprehensive way so that the patient can get a proper relief. Suppose a patient is having low backache and is the severe depression, unless until we are treating the depression, patient will never feel a pain relief whatever you may be doing. We may be doing an intervention, we may be doing anything, but every time the patient will be coming with a new pain which was not there earlier. So we have to look after these pain, because earlier first you diagnose is a facet joint, next time you will be seeing that the pain is radiating, next time you will be seeing it's on the left side, it was now in the right side. So that will be varied pain and there will never be treated. So both the things should be treated simultaneously.
Thank you, sir.
One question there, what are the contraindications of RFA? Radiofrequency ablation. What are the contraindications?
Radiofrequency ablation, particularly, as I said, if there is any red flags, particularly in those cases, we should not be doing. Now, these are the general contraindications where you cannot put a needle. Suppose normal contraindications to any kind of anesthesia. Suppose there is a skin reaction. Suppose there is muscle atrophy in those areas. Suppose there is a muscle paralysis on those areas, or any kind of red flags. So you should not be using radiofrequency or any kind of interventions in those areas. Otherwise, you can use radiofrequency in pretty any place you can use. Particularly, you can have to take care of when there is a patient is in pacemaker, that you have to take care. You can keep somebody, because these are again monopolar. If you are using a bipolar RFA, then it is fine. Otherwise, if you're using a monopolar RFA, then you have to take care. Otherwise, we can use it pretty well in all the patients.
Is there any contraindication for epidural injection or via buttock region between the greater trochanter and ischial spine?
For sciatica, first one, is there any contraindications for
sorry.
epidural injections in hypothyroidism? No,
And
there is no
uncontrolled diabetes.
contraindications in hypothyroidism or uncontrolled diabetes mellitus, because steroid we are not giving into the intravenous area. That is basically will be staying in a particular area. These are depot preparations, so there won't be any complications, but it should not be repeated too frequently. Now, for sciatica pain injection, which approach will be better, epidural injections or via buttock injections between the greater trochanter and the ischial spine? Now, you were talking about a suppose sciatica pain. Sciatica is a vague term actually. It is not a diagnosis. Sciatica, what we say, is a presentation. Patient will be feeling pain along the distribution of the sciatic nerve. It can be L34, it can be L45, it can be L5S1, it can be anything.
Yes.
So, according to the which nerve root is affected, transforaminal root block is much better than any. This one is better, means transforaminal is better. Particular nerve root which is affected should be used. Then what do you prefer, PRP or prolotherapy, and in what conditions specifically? Particularly tendinopathies or where there is cartilage damage, particularly tendon damage. In those areas, PRP is better than prolotherapy. Again, prolotherapy is not that much recommended, but earlier, because PRP was not there, we were using. But if you look at the compare the growth factor mobilization, it is more with the PRP. So it should be more preferred than prolotherapy. Complication rate is almost similar. It's nothing like in both, but result wise, if you see, PRP is much better than Prolo. And which conditions, as I said, particularly tendinopathies in golfer's elbow, Achilles tendinitis, tennis elbow, anywhere where there is a tendon involved because of inflammation or because of degeneration, we can put PRP and we can heal that area. Now, what severity in terms of spinal column diameter in case of lumbar canal stenosis without red flags, we can go for adhesive lysis. Now, adhesive lysis, there is no clear-cut guideline that at which diameter we can put a steroid injection. There is no clear-cut guideline. But if there is no red flags, and we can go for an epidural injection, as I said, epidural, if it is transforaminal, is always better. There is also a spread into the epidural area so that the complication rate will be. But there is no clear-cut indication at which level, means if it is 7 mm, if it is 8 mm or 9 mm, below which we should not use, there is no clear-cut indication. Because same time, if you look at the cervical level, there is no gap at all. But we are going for a cervical epidural because at that cervical level, the gap is very minimal, but we are doing it. So you should be clinically, you should judge it, and accordingly you should do it.
Okay, thank you, Sovan. There are no more questions, and already it's time. We have to wind up. So thank you very much. You have accepted the invitation, and you.
Sir, I'll be waiting to show these procedures at least physically
Yes,
to
yes.
everyone. So
We
that
will have one physical mode that time. Certainly will arrange that. Today we failed to do that, but certainly will arrange for a physical mode. We will demonstrate it, and we all will enjoy the procedure. And I must thank all the office bearers of Odisha Association of Physical Medicine Rehabilitation and my friend of Indian Anesthesia Association of Anesthesia as well as Pain Medicine. And I must thank all the participants who have joined in this webinar. And we are really thankful to Dr. Professor Sovan Rath for his excellent lecture on this basic management of chronic pain. And thank you very much. I thank you once again. I thank you all, and good night. Thank you.